Thank you very much, and good morning, everybody. Today I would like to talk to you about PrEP and cost effectiveness. We all know that PrEP is highly effective in preventing HIV, yet only few countries have decided to reimburse PrEP. And most importantly for that is that there are a lot of political challenges. That's something that is a very important topic of this conference, but something that I will not address. Another topic that is very important for governments and for policymakers is the cost. And for policymakers it's very important because the money that they will spend on PrEP cannot be spent on something else, like a smoking cessation program or a road or education, something that is also for the common good. If you want to assess whether something is cost effective, you have to take the cost-benefit balance into account. And the cost of a PrEP program can be substantial. There have been estimates that for every 62 persons that take PrEP, only a single infection are averted. That means that you treat 61 individuals with PrEP, whereas they do not have a benefit. But those are costing money. On the other hand, the benefits. You can have substantial health gains in a population if you give PrEP to a sufficient large number and if you target it to those individuals at the highest risk. And on top of that, you can reduce future costs simply because in the future you do not have to treat all those individuals with HIV, which is over a very prolonged time and which can be very expensive. So the aim of my talk is to assess or to explain to you what the cost effectiveness of PrEP in the Netherlands and in Germany. Those two countries were chosen because the Netherlands, that's the country where I'm based, and based on a paper that we published in Lancet Infectious Diseases in 2016, we were invited to repeat that analysis for Germany. And we published that earlier this year in Eurosurveillance. By the way, as Valérie already explained, these are not the only two countries where cost-effectiveness analysis have been performed. There are also data from the UK, from Belgium, and from France, and probably also from another few countries. So let's first go to the methods that are used in cost-effectiveness analysis. And I would like to tell you that cost-effectiveness analysis on a topic such as PrEP are very complex. On the one hand, you have an individual benefit. So every individual who takes PrEP at average reduces the risk or his or her risk by 85% according to the IPRGay and PROUD randomized control trials. But it becomes more complex is that the sexual partners of those people on PrEP, even though they may not take PrEP, may also be protected. Somebody who takes PrEP and as a consequence is not getting infected, who has 3 sexual partners in a month, and those 3 sexual partners are also protected. So you have a population effect, secondary infections that are averted. And the transmission model can be used to evaluate the complex dynamics of HIV prevention. And the analysis that I now show are focused on HIV. Now let's first go over how a transmission model actually looks. There's a lot of math behind this, a lot of mathematical equations. And I was told that every time you show a mathematical equation, you lose 50% of your audience. I decided not to show those mathematical equations because last night I did the calculation based on how many people there are in this audience. And I think that only the person here in the front is the only one still paying attention. So I will not do that. We have one single person left. So I'm going to tell you in a more general overview what the model looks like. First, people will not have HIV. If somebody gets HIV, they will go to the acute stage, which is brief but highly infectious. Then after 10 to 16 weeks, people progress to the chronic stage, which takes about 8 to 10 years. And we subdivide the chronic stage based on historical treatment guidelines. So in the past, we first said we have to treat everybody with a CD4 less than 200, then less than 350, then less than 500, and now everyone. The reason why we did that is because it can help us to calibrate and compare our model with the CD4 cell count at diagnosis, but also with historical treatment guidelines. Then if people do not get diagnosed in time, they can progress into AIDS, and unfortunately, in every single European country, we still have people admitted into hospitals with AIDS symptoms. and then they go to treatment. And when they have an undetectable viral load, they cannot transmit the virus to others. What we then did is we simply assumed that an individual that does not have HIV has a particular probability of getting infected, which depends on the proportion of individuals in the acute stage, the proportion of individuals in the chronic stage and in the AIDS stage, times the transmission probability of all those stages. What we did is we calibrated those models, so we compared it with the historic epidemic in both the Netherlands and in Germany. And we were able in our model to compare that, and then we introduced PrEP. And when we introduced PrEP, we assumed that people can start PrEP and can discontinue PrEP. And that at average, PrEP gives a reduction of 85%. Now, what we do in a cost-effectiveness analysis, and that's the effectiveness part, that's the end, is this is always expressed in studies, in cost-effectiveness studies, as a so-called quality-adjusted life year. And that's for all the studies. So cost-effectiveness studies always compare cost on the one hand and quality-adjusted life years at the other hand. So it's always the same. And in theory, this would allow policymakers to pick that intervention that is most cost-effective and gives the best value for money. The way that it is actually done is that a quality-adjusted life year is being expressed as a value between 0, which is death, and 1, which is lived in perfect health. We assume that a person using PrEP is healthy, and therefore we assume that they have a QALY of 1. And then in the table below, you can see in the left-hand side the particular stage of the infection, and at the right-hand side, the corresponding value. So you see, we go from 0.94 if somebody is still early on in the infection or is on treatment, and we go to 0.7 if somebody has AIDS. What you then do is you run your model, and you compare two scenarios. The first scenario is when PrEP is not available, and then you calculate the cost compared to when PrEP is available. And you divide that to the gain in QALYs in the two scenarios. Something that we always do in a cost-effectiveness analysis is we use discounting. And the discounting rate that we used was 3%. That means that the cost that we have right now in this year, if we start implementing PrEP in Poland, then all the zlotys that we spent in this year are given a weight of 100%. The zlotys next year, 97%. 97% of that, etc., etc., etc. The reason why we do that is we want to give a bigger weight to the cost that we have in the short term as compared to the long term. Because you do need a very long-term analysis like this. Somebody who takes PrEP and who does not get infected, that we do know that people at the age of infection in the Netherlands and in Germany is between 30 and 40 years. These people can still live for another 40 years. So they have a health benefits of 40 years. So analyses like this are being done over a 40-year time horizon. Then the willingness to pay. We say that if it's below this threshold, we say it's cost effective. There's not really a good threshold in the Netherlands and also not a good one in Germany. The only one that has a good threshold is actually the United Kingdom, where they use £30,000 per QALY. Now let's have a look at the cost that we took into account. When I was doing this analysis, or when we were doing this analysis, what we found is that the patent expired on Truvada. As a consequence, the price dropped. We used 50 euros per month, which was at that time the cost of PrEP both in the Netherlands and in Germany. It's much lower now, but it was the cost that we used at that time. Then you take into account the cost of PrEP care, so creatinine levels that has to be measured, HIV testing that has to be done, STD testing, costs of the nurse, of the doctor who's prescribing PrEP, etc. And we compare that with the treatment with antiretroviral drugs. And in our countries, that is extremely high. 13,000 euros in the Netherlands. And in Germany, it's even more expensive. It seems that everything is more expensive in this respect in Germany. The reason why Germany is more expensive also has to do with the healthcare costs. We took this analysis from a payer's perspective, so from the health insurance. In Germany, health insurance starts paying for sick leave after somebody has been reported ill for more than 6 weeks. That is something that we don't do in the Netherlands. So as a consequence, the price of treatment goes up. Now let's have a look on the impact, so the health gains on the epidemic. What you can see here on the vertical axis is the cumulative number of infections prevented for the Netherlands. Valerie already showed them for Germany. And the year can be shown in the horizontal axis. We thought that we could implement PrEP in 2015, so we published this paper in 2016, and then the red bar shows if the effectiveness is 40%, and the black bar shows if it's 100%. So if this is the case, and you target 10% of high-risk MSM, you can have a pretty big, substantial impact on the epidemic. And something comparable was actually found in Germany. When we were doing this analysis, PrEP was still protected by a patent in the Netherlands, and the price at that time per year was more than 7,000 euros to use PrEP. But we knew that the patent was going to expire, so we had discussions amongst ourselves like, how much will the cost decline? And we simply didn't know. So we did an analysis like this. This is a two-way sensitivity analysis. The vertical axis shows the decline in cost with 10% increments, and finally the effectiveness in PrEP is given on the horizontal axis. In the red bar you can see the price that we're paying now for PrEP. So after PrEP patent expired, the price went down with 90%. And you can see in dark green that in most cases, even if PrEP on a population level is modestly effective, is that within 40 years, all the money that you invest now in PrEP will be gained back. This paper has been part of an official advice to the Dutch government by the Health Council. And based on this paper and also on the evidence that is out there that PrEP is working, the Dutch government decided to partially reimburse PrEP. So these papers work. Then I repeated this analysis for Germany. But what I found in Germany is that the difference in price between treatment and PrEP is so much higher that the gain or the time to gain the money back is actually much shorter. And that is shown here by this camelback plot. This shows the break-even point. On the vertical axis, you see the cumulative costs, and on the horizontal axis, the years since implementation of PrEP. What you do see is, for instance, if you take a look at the red bar, that's 45% effectiveness, then you can see that the cumulative costs peak after 10 years at almost 300 million euros. After that time, it goes down. That means that you start gaining back money simply because you start to avert all those infections. And the time when Germany actually starts to gain back money is between 9 and 15 years. This is perfect, but for politicians that could be a problem because they think in periods of 4 years. And that's a lot of Angela Merkel's, and she decided to step down, or in my case, our Prime Minister Mark Rutte, who's also in power for 10 years. But that's not always the case. Look at Britain, where we had a lot of prime ministers so far. But I'm not mentioning the B word now. So you can see that you gain back money. Another thing that we know in the Netherlands is that when Tenofovir and Tenofovir disoproxil fumarate lost its patent, we now have TAF. So patients are actually being substituted to TAF. There's a whole discussion whether that's a wise decision to do or not. But you may assume that in some cases TDF may also be used, and actually policymakers say, why don't you prescribe TDF to your patients, and only with patients that have problems due to TDF, you give those TAF. That will also reduce the price and will reduce the price difference and make PrEP less cost-saving. I think that very high cost savings are not likely because dolutegravir, both in the Netherlands and in Germany, is very popular and is still very expensive. But let's have a look what we found if we did that. You can see the horizontal axis, the costs after 10 years. So again, with increments of 10 years, what if the price of antiretroviral treatment goes down? The effectiveness on the horizontal axis, dark green means that it is cost saving after 10 years, and dark red means that it is very expensive. What you can see is that if you reduce the price, then in general, within 10 years, it's more expensive and you do not gain it back. So we also estimated when the break-even point is being reached. Again, the price, the decline in price is given on the vertical axis and the effectiveness of PrEP on the horizontal axis. Dark green means that within 10 years, light green between 11 and 15 years. So you can see that even if the price of antiretroviral treatment is declining, then even in that case, we will see that we will gain back money. In other words, if we invest money in PrEP now in Germany, but also in the Netherlands, it's very likely that we gain back that money within 2 decades. And I've not spoken about the health gains yet. So this brings me to my conclusions. I have to say, and this was also mentioned already by Valérie, is that these models, I love them. I really like working on them, and I like the math behind them as well. The transmission models are very important, but you have to know that they also have limitations. First of all, we take 40-year time horizon simply because we want to see what the long-term impact is over somebody's health life or over somebody's lifetime. But the disadvantage is in 40 years, a lot of things can happen. 40 years ago, we had not even heard of HIV. But this is the way it is. That may be a limitation. Another thing in these models is we make some assumptions about risk behavior. And I've had lots of discussions about how risk behavior should be implemented, and lots of people gave me suggestions, and I have not seen any good solution to that. But that is a limitation. If you ask individuals who are at risk of HIV, you get very wide ranges. And we're not sure if the truth is always being told, or the truth, or, you know, what is out there. The reality, that's a better word, if the reality is being told. That's a limitation. Nonetheless, it's what we have. Despite of that, implementation of PrEP has health benefits. I'm focusing here on the cost, and that's a reason because costs are so important and the drugs are so expensive. But the first thing is we have health benefits to gain with PrEP. Second of all, it is cost saving. And this strongly depends on the difference between the cost of PrEP and the cost of treatment. I showed you here for the Netherlands and in Germany. In Germany, PrEP is actually more cost saving and is cost saving at a much shorter time span simply because the difference between the drugs is so much bigger as compared to the price of PrEP. That's one of the things. We also had papers here from the United Kingdom, and I especially would like to mention the paper by Valentina Cambiano and her colleagues, some of them are also in the audience today, that was published a few years ago. You have to know that PrEP requires economic investment. You have to invest now and save money in the longer term. And finally, this is work, I could not have done this alone. Special thanks go to Brooke Nichols, who did a lot of work on the Dutch model. And I would like to thank DACNA for the funding for performing the model for Germany. Thank you very much.
We have one question.
Thanks, David. In the beginning, you asserted that it takes 62 people on PrEP to avert one infection. And my question is, doesn't that really depend on the prevalence in the community, and doesn't it vary across communities depending on the prevalence? So where did you get the 62?
Thank you for this question. I should have added that. The 62 was in general, it was a paper by Susan Bookbinder who based it on the IPREX trial. IPREX had a very small impact, so it may be larger, but in the same paper she also showed that men who have sex with men who have a lot of STDs, in those individuals it's actually 10. So 62 is a moderate estimate.
Hello, thank you for your presentation. I think policymakers really like to have this kind of studies there. I do, however, have three concerns about this kind of study. One is that I assume that you are looking at daily use of PrEP, that you have not really considered on-demand PrEP, or the fact that more people are sort of switching on and off PrEP and so on. That seems to be the future mode. The second issue is around that I think in many countries they found that the cost of providing the service to make PrEP right is higher than for the drugs itself, actually, and should also be considered in this. And finally, I don't think that you are considering the synergies. Like, for example, if more people have access to PrEP, maybe that will get much more people to go in for testing and be put on treatment and so on. So in a way, I find the model a little bit simplistic, I would say.
Thank you for these questions. So your first question was whether we considered on demand. We did that for the Dutch paper. We did not do that for the German paper. In the Dutch paper, we actually showed that if you do on demand, it's far more cost effective. The second question was on the services. Is that right? If you do increase the services, it's absolutely true that by testing more frequently, you would, in a way, also reduce the number of infections simply because you test more frequently. That's absolutely true. We wanted to have a worst-case scenario, so therefore we did not consider that. Finally, the cost of the services may indeed be much higher. What we did in all those cases is we actually went out, and especially in Germany, where we simply said, like, what is all the cost if we provide this type of care? So in my view, especially in the German paper, we did consider all those costs and took them into account.
Thank you very much, David, for your very interesting presentation.